Good evening, guys. I'm Dr. Asif Nawaz. As the continuation of the previous videos, I'm going to start the MRCS study plan. Today's video is not too long, but maybe finishing part of surgical physiology and also the attachment of anatomy, because in the pathology sections, we all know that repair, regeneration, and healing is one of the important chapters that is very much necessary for surgical practice. So here this is the part that discussed in the physiology portion, but the topics is from anatomy, and not anatomy, that is pathology, the wound healing. Okay, so firstly, this is the first topic of pathology, that is the wound healing. So there are several phases of wound healing: hemostasis, inflammation, then regeneration and remodeling. So this important organism, that is cellular organism, that is involved in these stages of inflammation, like neutrophil, fibroblast and macrophage are present in the inflammatory phases. So they are within the days features, and the regeneration, that is fibroblast, macrophage and also the epithelial cells. Okay, these cellular organisms are present within the weeks. Okay, weeks from the time period of wound. Then remodeling phase, the last phase of inflammation, which may be present 6 to 1 year, and here the myofibroblast is necessary. That is, this is the organism which is necessary for remodeling phase. So there is an MCQ in the EMRCS, that which cell or cellular substance are present in the in our wound which is about 6 to 7 months old. So what organism is present? That is myofibroblast, or the wound contraction which is happened by the myofibroblast. So hemostasis is the first mechanism, that is vasospasm of the adjacent vessel, and then platelet plaque formation and regeneration of fibrin clot. Okay, so here the erythrocytes and platelet are usually present, which works within minutes or seconds. Say in the remodeling phase, there is collagen fibers which is necessary, and maybe formation of scar. Fibroblasts become differentiated. Long last phase of the healing process may last up to 1 year. Okay, this is the long period. And the regeneration, platelet derived growth factors. So platelet derived growth factors and transformation of growth factors stimulate fibroblast and epithelial cells. Okay, so must remember platelet derived growth factors, PDGF, and the transformation of the growth factors stimulate fibroblast and epithelial cells, that causes initiation or give stimulation for regeneration. Now the response to surgery. So there are some hormonal response which is mainly triggered after the surgery or by the surgery. First things first, the sympathetic nervous system. We all know that every stressful stimulus can increase sympathetic outflow, that is nervous system. Surgery is one kind of stress, we all know that. So here the noradrenaline from sympathetic nerves and adrenaline from the adrenal medulla comes from due to surgery. Blood derived from skin and visceral, like bronchodilation, reduced intestinal motility, then increased glucagon, and the glycogenolysis and insulin is reduced. So here the bronchodilation and the noradrenaline from the nervous sympathetic nerve, that is postsynaptic sympathetic nerve ganglion, and another one is adrenaline which comes from adrenal medulla. And the blood related, that is bronchodilation of the respiratory system, reduced intestinal motility, that is ileus. So after this during the surgery, so abdomen may be distended or paralytic ileus or ileus related disorders, that is dysmotility syndrome or temporary dysmotility can be occurs, and the increased glucagon activity, that is anti-insulin like activity, that is glycogenolysis from the liver, and the insulin is reduced. So which hormone is reduced after surgery? The question answer is the insulin. Heart rate and myocardial contraction are increased, so that patient might cause tachycardia, or increase cardiac contractility. So there are some acute phase response. So after inflammation there is some acute phases which is mainly found in the blood, that is tumor necrosis factor, interleukin 1, 2, 6, interferon and prostaglandin are may be found, and excess cytokines may cause SIRS, that is syndrome of inappropriate systemic inflammatory response syndrome. If we say what kind of this, so systemic inflammatory response syndrome. Okay, so that is one of the important things. So cytokines increase the release of acute phase, no need that SIRS is very important. Okay, now there are some other hormonal activities may be increased after surgery, that is pituitary adrenal axis, increased ACTH, cortisol production is also increased protein breakdown, that is catabolism. I already discussed about the belly love session. There are some other videos of belly loves. In that case I already give a lecture about this metabolic response to injury. In the first chapter of the belly lab, there I usually broken down the what happens in the daily physiology after surgery. I already discussed in that session. So increased blood glucose level, that is due to increased glucagon or increased glycogenolysis. And there are some other hormones, that is aldosterone increase sodium reabsorptions, and the vasopressin increases water reabsorption and causes vasoconstriction. Now the vascular endothelium, that is nitric oxide, produce vasodilation. So what happens in the blood vessel, that is peripheral vasodilation by nitric oxides. Then platelet activating factors enhancing the cytokine response, prostaglandin produce vasodilation and induce platelet aggregation. So these are all happened in the vascular endothelium. Okay, now the other stresses. So in short, please see here, that is surgery precipitates hormonal metabolic changes, and the stress response associated with substance mobilization, protein loss, that is catabolism, and sodium water retention followed by edema. Okay, and some suppression of anabolic hormones and activation of sympathetic nervous system, immunological and hematological changes. So you can read here for proper acquisitions. Now in summary, what are the hormonal changes? Very very important, not only for MRCS but also any PG exam. You will know, or you will get a question from this chart, that is the hormone increased during stress, that is growth hormone, then cortisol, that is stress hormone, renin, renal system, that increase the BP or blood pressure by the renal system. These hormone come from liver and activate in the kidney. Then ACTH, adrenocorticotropin hormone, aldosterone, prolactin, antidiuretic hormones, and the glucagons. These hormones are increased during stress. So those all are catabolic hormones that will increase blood sugar, and which is all the diabetogenic hormone. Another one is decrease, that is insulin, testosterone and estrogen. So gonadal hormone and insulin is decreased. In that case, that's why any kind of stress causes decreased libido and also hyperglycemia or increased insulin resistance. Okay, cause more making hyperglycemic. So what are the hormones that has no change? That is TSH, thyroid releasing hormone, causes thyroid stimulating hormone, luteinizing hormones, and the follicle stimulating hormones. Now the sympathetic nervous system stimulates catecholamine, that is I already discussed that sympathetic system increases noradrenaline and adrenaline from the medulla. Okay, that is and causes tachycardia and hypertension. And pituitary hormones, that is ACTH, growth hormones, and preoperative increased prolactin causes inhibitory control, has no change. That is, this chart is described here. If you go through the PDF, you can see what kind of things it is written here, because everything is described in this chart. Try to memorize this chart. And negative feedback, these hormones are maintained by negative feedback. When the stress response is relieved or are diminished, that hormonal response also diminished. Okay, so cortisol has some other effects like skeletal muscle protein breakdown effect, stimulation lipolysis, anti-insulin effect, mineralocorticoid effects, and also the anti-inflammatory effects. That's why it is used in reducing inflammations with the help, like in the acute stressful infectious condition, we can use steroid like cortisone or dexamethasone we can use. Now the growth hormones also has a minor role, but it's necessary. Most important for preventing muscle protein breakdown, promote tissue repair by insulin growth factors. Alpha endorphin, that is endogenous morphine or endogenous pain relieving substance, is increased. It's definitely because due to surgery is a stress, is a cut, so there is a tissue injury, so there is a stimulation of pain. So body itself has endogenous analgesics, that is endorphin, which is usually increased after surgery. Now the antidiuretic hormone is important vasopressor and enhances the hemostasis. Renin is released, causing conversion of angiotensin to 1. Angiotensin 2 formed by ACE, and angiotensin 1, which is secretion of aldosterone from adrenal cortex, and increased sodium reabsorption at the distal convoluted tubule. So here is a chart. What they said about stimulation of insulin, that is glucose, that is glucose rich food or fluids, amino acid, that is protein rich fluid or food, vagal cholinergic, that is vagus stimulations, that is parasympathetic stimulations, secretion of gastrin and CCK, and fatty food, that is fat related food, that is high dietary food like milk origin or sweeteners, or also some fast foods. These all are fatty foods, which is increased stimulation of the insulin release. And some beta blockers, inhibition of the insulin release, that alpha adrenergic drugs, that is beta blockers, and sympathetic nerve, that is stressful condition, and alpha adrenergic, that is all are the catecholamine related effect. So here is another thing, that insulin release inhibited by stress. This question is came in the post graduation examination like FCPS. I already faced this exam 2 times, and it occurs by inhibition of the beta cells by the pancreas by the alpha 2 adrenergic and inhibitory effects by the catecholamine. So in case of post-operative period, you must infuse insulin from the external sources, because in that period the body cannot increase a adequate amount of insulin that the patient might need is not sufficient. In that case, you have to give insulin by drip or intramuscularly, TDS, that is 3 times daily. Now the thyroxine and triiodothyronine, which is considered to be inversely correlated with sympathetic effect, and after surgery there is a reduction of thyroid hormone production, which is normalized over a few days. Now, metabolic effect of endocrine response, that is carbohydrate, protein and lipid, and salt and water. So hyperglycemia is a main feature of the metabolic response due to increase in the glucose production, reduce glucose utilization. So increase production but reduce utilization, that's why hyperglycemia occurs. And the catecholamines and the cortisol promotes glycogenolysis and gluconeogenesis, that is carbohydrate used from non-carbohydrate precursors like protein or fat origin. Initial failure of insulin secretion is followed by insulin resistance after the normal response. The proportion of the hyperglycemia response reflects the severity of disease. Hyperglycemia impair renal healing and increase infection rates. Now the protein metabolism. Initially there is an inhibition of the protein anabolism followed later if the stress response is severe by enhancing the catabolism. So initially catabolism, then anabolism occurs. Okay, anabolism means that is insulin is anabolic hormone which helps to produce like glycogen, like lipid, so that is fat, adipose tissue, and also the preventing the muscle damage. That's why. And protein metabolism is increased, or protein formation is increased by insulin. That's why due to insulin a patient's weight might be increased. And in case of diabetes mellitus, a patient is sometimes become cachectic due to excessive catabolic effect, and there is no or reduced anabolic effect due to absence or reduced presence of insulin. Increased catecholamine, cortisol and glucagon secretion and insulin deficiency promotes lipolysis and the ketone body productions. Salt and water metabolism, the ADAs causes water retention, concentration of urine and the potassium loss may continue up to 3 to 5 days. Renin causes sodium and water retention. Now cytokines, glycoprotein, interleukin 1 to 7, interferon, tumor necrosis factor, synthesis by activated macrophages, fibroblast cells. Then interleukin 6 main cytokine associated with surgery, which is peaked to 12 to 24 hours of surgery, increased by the degree of tissue damage, because the more tissue damage, the more formation of cytokines in interleukin 6, and that causes fever, granulocytosis, hemostasis, and tissue damage in limitation, promotion of healing. So these are the cytokines is released 1 to 17 and 6, interferon, tumor necrosis alpha. So these are the cytokines came for exam, not in the MRCS exam but also in the PG exam, others. So there are others hormones, because everything are related with the same thing. Then like nutrition prevents adverse effect of stress response. So early feeding is very necessary for ERAS, that is enhanced recovery program or protocol. We must give the patient postoperatively as early as possible, because it helps ERAS procedure as early as possible, that is enhanced recovery process. And the growth hormone and anabolic steroid may improve outcomes. So sometimes we may need to give load steroid for increased outcomes. So enteral feeding improves, and normothermia decreases the metabolic response. So sometimes we must make the patient warmed, because hypothermia can increase the stress response. Now the shock is very important, that is where is insufficient tissue perfusion. There are many other causes of shock, because it depends on the cause, because if the organ is within the heart, then this is one kind of shock. If the blood volume related issues, then that is another kind of shock. If there is neurogenic problems or obstructive problems of blood flow, that can cause another kind of shock. So classification of shock is very important. Another one is infection related, that is septic shock. So hypovolemic shock, which is related with the blood volume related issue. If there is a massive surgery, massive road traffic accident, or a massive burn, there is the limitations of volume or plasma flow. In that case, that is called the hypovolemic shock. If the heart is not about to compensate or make supply to the distant places, in that case it is called the cardiogenic shock. Or heart fail to pump adequate blood to the circulation. And another one is neurogenic, that is spinal cord injury or nerve resection related, or the malignancy surgery. In that case, we have to sacrifice some nerves, that causes numbness or paresthesia paralysis. That is called neurogenic shock. And another two kind of shock, that is distributive and the obstructive. So blood flow obstruction is related to the obstructive shock, like pulmonary edema, pulmonary embolism, or heart failure, or liver failure, or at least lung failure. And the last and most important one is a septic shock. That is, more infection can causes more chances of deterioration or multiple organ damage. Like I already said about the systemic response, inflammatory response, RS has some criteria. That is body temperature 36 to 38, heart rate is more than 90 beat per minute, respiratory more than 20, and WBC count more than 12,000. So altered mental state or hyperglycemia causes SIRS. So septic shock is a major problem. Severe mortality rate is 40%. So patient with infections and 2 or more elements of SIRS meet the diagnostic criteria of sepsis. Organ failure may be severe sepsis, those refractory hypotension and septic shock. So in case of septic shock, hypotension occurs because this is a sign of multiple organ damage. And it also helps to create excessive cytokine release. And the overall hallmarks of the excessive inflammation, coagulation, and fibrolytic suppression. Fibrinolytic suppression, that is blood coagulation disorder occurs, that is DIC, and excessive inflammation, followed by SIRS. So in that period, cerebral venous pressure, that is 8 to 12 centimeter of water, and mean arterial pressure is more than 65. It's an ideal. We have to establish these two things within the SIRS for resuscitation. Now, in the surgical patient, the main group of septic shock, those with anastomotic leakage, abscesses, and extensive superficial infections and necrotic fasciitis, that is polymicrobial infection. So in case of specific surgical patient, we usually found the patient with anastomotic leakage, or multiple abscesses, or extensive superficial infection like Fournier's gangrene, like Meline's gangrene. So when performing surgery, an aim should be undertaken the minimum necessary to restore the physiology. These patients do not fare well with prolonged surgery. Definitive surgery can be more safely undertaken when the physiology is restored. Clotting in particular has been normalized. It says that if the patient has this kind of symptoms, so we might need to stop surgery if it is not emergency, because we will treat the patients conservatively so that the patient come for the to normalize all the others parameters, and then when the patient is fit, we will go for surgery. Sometimes surgery might causes this kind of sepsis, so it needs time to heal or recovery. If the patient came delayed, or if the patient performed surgery in the remote area or remote hospitals where there is no ICU support, in that case, or the remote areas, the death is inevitable. So there are some classification of hypovolemic shocks. So if more than 75 ml of class 1, if the loss is 751, 1500, then class 2, 1500, 2000, class 3 or more than 2000, that is class 4. So that is 15%, 50 to 30%, 30 to 40% and more than 40%. So this is the classification of blood losses. Okay, and so cardiac index, what is the cardiac output and body surface area? So cardiac index gives a numerical value of tissue oxygen in delivery and given by the equations. And the obstructive shock, obstructive, that is tension pneumothorax, the lungs is collapsed, that prevented to expand and obstruction occurs. Then spinal cord injury, that is neurogenic shock, myocardial contusion, or cardiac tamponade, that is cardiogenic shock. But cardiac tamponade is also an obstructive shock because pericardial fluid is increased and heart fail to pump. It is one kind of obstructive shocks. But some bookish authors say that it is cardiogenic shock, but in the latest version of MRCS, or not only MRCS but the syllabus, that is cardiac tamponade is within the obstructive shock. Remember that very clearly. So this is the neurogenic shock, spinal cord injury, and the sympathetic and parasympathetic tone is reduced, and marked vasodilation, and reduce the peripheral vascular resistance. Cardiogenic shock, that is ischemic cardiac disease, and evidence of ECG changes, condition rise, suspicions of injury. Cardiogenic shock in the pulmonary pressure around high is the basis of use of vasodilators, treatment of pulmonary edema, that is verapamil or diltiazem, that causes vasodilation of the pulmonary vessels, because these are the calcium channel blockers. So measurement of troponin levels, trauma patient may be undertaken by less useful delineating the extent of myocardial trauma following MI. So anaphylactic shock is another one that is very important and life threatening. Sometimes we can see some drugs has some anaphylactic reaction to particular patients, like I define as severe life threatening or hypersensitivity. For treatment purpose, you have to give, if the less than 6 month patient, a 0.15 ml in 1000 ml adrenaline solutions. If 6 months or 6 years, then 1.5 milligram to 1000. Adult, then 500.5 ml 1 to 1000. So hydrocortisone is usually used here. Chlorpheniramine also is, but not used nowadays. So these things are also added with the adrenaline solutions. So what are like some nuts, some venom straining drugs? So these causes anaphylaxis. Urinary incontinence. This is the sections of urology, not for pathology at least. But in short, they describe this. But I will going to discuss it in the urological section. Urology. Okay. Adrenal physiology is also already told that this is a biochemistry, that is vitamin deficiency. You have to continue these all things by your own. That is, you all know this very clearly, that which vitamin causes which kind of deficiency. But in case of C and collagen fibers, you must remember that. And vitamin B12, that is pernicious anemia. Another one is epithelial atrophy, beriberi, and the rickets and osteomalacia, vitamin K clotting disorders. So vitamin B12 deficiency mainly used to body to rate blood cell development, also maintain a nervous system. And it is absorbed after binding intrinsic factors and actively absorbed in the terminal ileum. Okay, a small amount of vitamin B12 passively absorbed without being bound to intrinsic factor. It is so much negligible. So what causes vitamin B12 deficiency? That is pernicious anemia post gastrectomy due to deficiency of intrinsic factors, poor diet, vitamin B12 non-containing diet, and disorders of terminal ileum or absence of terminal ileum, like Crohn's disease. So features of vitamin B12 like macrocytic anemia, sore tongue and mouth, neurological ataxia, mood stabilizer. If no neurological involvement, 1 to 1 milligram IM hydrocobalamine 3 times a week or 2 weeks. Also deficient folic acid, important for treating B12. First avoid. Subacute combined degeneration of cord is very important because it is asked in the MRCS question bank. So there are some mimics for remembering, like increase mud piles, calcium channel, and then like methanouremia, diabetic ketoacidosis, lactic acid causes anion gap increase, like increase acidosis. Normal anion gap, that is renal tubular acidosis and diarrhea, acetazolamide. Increase potassium, like AC inhibitor, NSAID, metabolic and respiratory acidosis, cellular destruction, burn, hemolysis, nephrons related disease, thermocytopenia, ITP, DIC, and moderate thrombocytopenia causes heparin induced thrombocytopenia, HIT, drug induced, aspirin, quinine, alcohol, liver disease, hypersplenism, Epstein-Barr, HIV, hepatitis, pregnancy, yes, itself are causes of thrombocytopenia. And SLE, antiphospholipid syndrome, and vitamin B12 deficiency. Okay, so that is all about the pathology related physiology, surgery related pathology, though it is present in the physiology sections, but I used to see that it's within the physiology actually, but not in the physiology, but related with surgical pathology, because there is a chapter of metabolic response to injury. There everything is discussed there. So that is all about today's lectures. I hope you like my channels and I hope you like my videos, because it is beneficial for your normal basic as well as gain entry to the post graduation exam along with MRCS part A exam. So day by day the exam is tougher and the question pattern is changing, so I hope the preparation must be up to the mark following for the part A, and you all know that the examination is quite costly. So thank you very much for today's lecture, and after the next day we will go for soul pathology along with some surgery organ related pathologies. And thank you very much for presence, and please keep me on your prayers. Thank you very much.